The topic I'm going to present today is chart review from analysis on treatment satisfaction and medical expenses in patients with depression. This study is connected to the previous presentation by Professor Sang-Ho Kim. This R&D is a human subject study conducted at a single institution at Kyung University, Department of Clinical Korean Medicine. This is a study of patients who visited from August 1, 2022 to July 31, 2023. There were a total of 60 subjects with 30 divided into CP group and 30 into usual care groups. Let me introduce the contents to be presented. First, let me tell you about the purpose and necessity of research. And second, purpose of research and development, context and boundary of research and development results, plan for practical use of research. Since Professor Sang-Ho Kim explained depression earlier, I will only talk briefly. Okay, this is the purpose and necessity of research. And what is depressive disorder? Okay, usually in Korea, diagnostic groups including major depressive disorders and systemic disorders are classified as depressive disorders. So, what is major depressive disorder? It is a disorder that feels depressive or lose interest almost every day for more than 2 weeks and shows a decline in daily function. Then what is systemic disorder? It is a disorder that feels wet most days for at least 2 years, shows symptoms such as a loss of appetite, excessive sleep, and fatigue. And this is a depressive disorder. What about lifetime prevalence rate of depressive disorder? The prevalence rate of depressive disorder are 1.7 times higher in a woman than in a man. However, the prevalence rate of men is not as low as 5.7%. Then how about periodic prevalence? 2.2 times higher in a woman than in a man. It can be seen that the prevalence rate increases significantly after the age of 70s. So what proportion of the use of the mental health service does the depressive disorder account for? According to mental health service utilization, the depressive disorder account for the highest proportion. I'm also seeing a lot of patients in our hospital, even as I feel depression patients outnumber patients with other conditions, especially when they are over 60. Increasing depression with age is an important reason to be alert to depression in our society entering the aging era. Now let's talk about this R&D purpose and necessity of research. First, the technical aspect. The major depressive disorder, has a high prevalence and the burden of disease is also significant, and it is estimated that the burden will increase. The number of domestic people treated for depression is steadily increasing. And third, a clinical pathway, which means CP, has been developed for process construction, but there is no evaluation through clinical application. This article is basic of this R&D. In this article, the clinical pathway, CP, was organized and presented. Through the Korean medical treatment for depression, we intend to maximize the quality of treatment by shortening treatment hours, reducing medical costs, and increasing patient satisfaction. This is also a point, but the results were not incredibly significant. Next, economic and industrial aspect. This R&D aims to improve the accessibility of Korean medicine by achieving standardization of medical services. provision of high-quality medical services, and reduction of medical expenses. Next, the social and cultural aspect. The depression and suicide rates are on the rise since COVID-19. The Ministry of Health and Welfare of the Republic of Korea also recognized the seriousness of depression and designed it as an important task in the 5th Comprehensive National Health Promotion Plan. One of the main policy challenges is promoting mental health and preventing suicide. This is it. If you look at the mental health care section, you will see all what the Korean government views as dangerous: suicide prevention, dementia, and addiction. All the time, the issue is, and these three are highly correlated with depression. The basic base of these three is depression. Now, secondly, what about the future prospect? In a situation where the number of patients complaining of depression is increasing socially, the demands for Korean medical intervention in depression will increase. This is what I mentioned earlier. In addition to improving the ease of treatment for depression in the Korean medicine community, preparation are urgently needed to enhance the understanding of depression treatment in Korean medicine for medical personnel, the general public, and the patients in other fields. It is expected that the validity will be secured if the performance indicators are confirmed through the evaluation of Korean medicine research for depression through the clinical application evaluation of the current developed clinical pathway. To sum up, the purpose of the R&D is as follows: evaluating the performance of standardization treatment of depression through the clinical application, evaluation of pre-developed clinical pathway, securing objective data on the effectiveness and affordability of Korean medicine for depression in clinical settings, and exploring the direction of modification for final CP development and field application to Korean medicine. Next, the content and boundary of research. The following process was followed in this R&D. The major R&D content, number one, the exploring applicable to experimentation agency based on pre-development CPs and SOPs. And number two, clinical application, evaluation, research design, and performance indicators development. And this is the outcomes. Here I explain the clinical pathway we applied. When patients with depression visit, first, history taking, psychiatric personal interview, diagnosis, and assessment of suicide risk. If psychiatric emergency, yes, first aid and hand over the specialized institutions. If not, we do next. Questionnaire test, biofunctional medical test, consult if laboratory test, EKG, chest X-ray are necessary. Need consult? If yes, then transfer. If not, check if hospitalization is required. Then, if it is need, admit a patient and create a care plan. First, medication administration. Second, treat. Third, psychotherapy. Fourth, education and explanation. Chief complaint evaluation. Check the medication response and check the psychological symptoms. If satisfies discharge condition, the revisit for outpatient care. If not, do it again. When the patient come again, check chief complaint evaluation and check the medication response, check the psychological symptoms. If it is satisfied, the end of the treatment condition and the treatment. If not, do it again. What was most different from usual care? treatment was the questionnaire test and the biofunctional medicine test were administered to patients all at once. This is the Korean Medicine Hospital CP. And next, the number 3, conducting clinical application research in single institution. Number 4, analysis of performance indicator of CP clinical application study. And last, number 5, exploring CP modification plan reflecting the result of clinical application study. Now I'm going to show you the result of this study. First, let me tell you about the difference between the CP group and the user care group. To explain again, this study is a retrospective chart review. This is comparison of socio-demographic and characteristic between CP group and user care group. The CP group and the user care group were 30 people each, and the total number of the subject was 16. In the CP group and the user care group, 23, 76.76 and 23, 76.63 and 67% respectively, had a higher proportion of women than men in both groups. Among the total study subject, the highest age was 79 years old and the lowest age was 30 years old, and the most of the CP application and user care group were distributed in the age group of 0 to 4 years old and 51 to 60 years old. Among those who responded to the education level, 11 graduated from high school in the CP groups and 22 graduated from the university or higher in the user care group. Merit status was the most common with 50 and 20, and respectively in the CP groups are CP group and the user care group. The presence or absence of job was 80 in the CP group and 50% in the user care group, with the number of people who were unemployed and those who had jobs matching. Overall, the demographic characteristics such as gender, age, marital state, and job status between the CP group and the user care group generally showed similar patterns, but there was a difference in the degree of education. What I'm going to add here is there was a difference in education, so I will revise it later. However, education level has not effect on current R&D. This is comparison of clinical characteristic between CP group and the user care group. In the case of the engineering disease, 40% patient in the CP groups and the 30 in the user care group show that 25 out of 60 subjects had engineering disease. The period from the date of the outbreak to the visit of the research institute was the most common in CP group, with 9 for more than 1 year and less than 5 years, 11 for more than 1 year and less than 5 years in user care group, and 20 for more than 1 year and less than 5 years in both groups. The types of hospitals that the subject visit from the date of the outbreak include family medicine, international medicine, and rheumatology, gastroenterology, ear, nose, and throat, and otherwise neurosurgery, orthopedic, mental health medication, and pain medicine, Korean medicine and Korean medicine hospitals, and the mental health medicine visited the most in both CP application and user care groups. Now, this is the compare of the result. Number 1. This is a comparison of treatment periods between CP and user care groups. The comparing treatment period of the CP group and the user care group, The CP group averaged 55 days and the usual care group averaged 171.97 days, more than half the treatment period of the CP groups, and was statistically significant. And the second, the comparison of visiting frequency between CP and the user groups. Comparing from frequency of visit between the CP groups and the user care groups, the CP groups averaged 4.83 days and the user care groups averaged 20 days, more than halving the number of days of visits compared to the usual care groups and being statistically significant. And number 3, comparison of the medical expense between CP groups and user care groups. Comparing the total medical expense of the CP groups and the user care groups during the visit period, it was found that the cost of the CP groups decreased compared to the user care group in all times, all of which were statistically significant. And in the case of the medical expense incurred per visit days, it was found that the user care groups paid a higher cost in all times, but not were statistically significant. In the case of the cost incurred during first visit, the CP groups were all higher than the user care group, but there was no statistically significant difference. And during subsequent visit, it was found that the CP paid higher cost in user care group, and the patient paid was statistically significant. The average subsequent visit payment was found to have paid a lower patient burden in the user care group, but it was not statistically significant. Comparison of the satisfaction between CP groups and user care groups. First, the treatment satisfaction surveys consisted of total of four items and was conducted of all 30 people in the CP groups and 30 people in the user care group. It was found that the satisfaction slightly increased in all times in the CP groups compared to the user care group, but all were not statistically significant. There is something I should have written here, but I couldn't. So the comparison of questionnaire score change between CP groups and user care group. What is BDI? The BDI is back depression inventory. And this is created by R&T Beck, and this depression inventory can be self-scored. This is a 21-question multiple choice and self-report inventory, one of the most widely used psychometric tests for measuring the severity of depression. Comparing the change in the score between the CP group and the user care group, the change in BDI score was 3.77 points on average in the CP group and 3.1 point in the user care group. This score change in the CP group was higher than that of the user care group, but it was not statistically significant. And number 2, what is the STAY? The STAY is a psychological inventory consisting of 40 self-report items on a 4-point Likert scale. The STAY measures 2 types of anxiety: state anxiety and the trait anxiety. The full name is State Trait Anxiety Inventory. The STAY score change was 9.70 points on the average in the CP group and 7.53 points in the user care group. And the score change was higher in the CP group than in the user care group, but it was not statistically significant. The STAY, the trait score, change was 6.70 points on the average in the CP groups, and it's 5.6 points in the usual care groups. And the score change was higher in the CP groups than in the usual care groups, but it was not statistically significant. The STAXI, STAXI, the full name is State Trait Anger Expression Inventory, that provides objective and shortly scored measure of the person experience, expression, and the control of angle. The static state score change was 2.03 points on the average in the CP groups and 1.30 points in the usual care groups. And the scores change was higher in the CP groups than in usual care groups, but it was not statistically significant. The static trait score change was 2.8 points on the average in the CP group and 2.53 points in the usual care group. And the score change was higher in the CP group than in the usual care group, but it's not statistically significant. And the STAXI control score change was 2.76 points on the average in the CP groups and 2.50 points in the usual care groups. And the score change was higher in the CP group than in the usual care group, but it was not statistically significant. The STAXI expression score change was 1.63 points on the average in the CP group and 1.13 points in the usual care group. And the score change was higher in the CP groups than in the usual care groups, but it's not statistically significant. And last, the STAXI suppression score change was 3.00 points on the average in the CP group and 2.33 points in the usual care group. And the score change was higher in the CP group than in the usual care group, but it was not statistically significant. And the EQOD, this full name is Euro Quality of Life. It was a standardized measure of health-related quality of life developed by EuroQOL group to provide a simple, generic questionnaire for the use in clinical and economical operation and a population health survey. The EQOD score change was 1.14 points on average in CP groups and 1.14 points in the usual care groups, and the score change was higher in the CP group than in the usual care groups, but it was not statistically significant. The EQOD-VAS score change was 9.77 points on average in the CP groups and 8.63 points in the usual care groups. And the score change was higher in the CP groups than in usual care groups, but it was not statistically significant. Although the CP groups shows good result, all questionnaire scores, it was not statistically significant. This may be a good and not good outcome for study, but it can also be a good outcomes because it is also evidence that the treatment so far was not wrong. And since the satisfaction level was high in both groups, I think it would be good to take this result positively. So the conclusion of this R&D is follows. The CP groups requires a smaller treatment period and hospital visit frequency than the usual care group. And there was a difference in the education level between the CP groups and the usual care groups, but this not disturb the above study. Although the CP groups shows a statistically significant result in total cost, total non-reimbursement, and total charge, the average cost of payment was not statistically significant. However, it can be said to be a more economical treatment model because the total cost paid has decreased in all items. Total cost and total reimbursement and total non-reimbursement and total charges. The CP group resulted in higher treatment satisfaction than the usual care group in all times. The above results were not statistically significant expected for the treatment period, visit frequency, and total cost of the payment, but they are meaningful in terms of confirming the tendency. This is the last, the plan for practical use of research. Now, expected performance and utilization plan are as follows. The expectation of revitalization of Korean medical treatment for neuropsychiatric patients through standardization of depressive Korean medicine treatment, creating a new model of depressive Korean medicine treatment suitable for the medical reality of Korean and creating evidence for it. Application of Korean medicine treatment system for depression, and improving patient access to depression and enhancing coverage. And last, the standard treatment through the guidelines in clinical settings to promote the levels of Korean medicine treatment for depression. And advancement of medical care through the development of diagnosis and treatment necessary for Oriental medical treatment for depression. And use of depression in clinical research and clinical and educational application. What I personally felt while doing research was that the peoples are weak when it comes to being visible. I think that the difference between the two groups in this study was due to the questionnaire test and the functional test. The patient trusts the questionnaire result and the functional test result, and their satisfaction seems higher when they saw this score. They also had expectation about the treatment and showed a willingness to get better. Contribute to reducing medical cost and improving patient satisfaction and stabilization to the national health insurance financing through the most efficient Korean medical treatment for depression, and use it as a data to improve access to medical care and enhance coverage for depression in patients. Thank you. And this research was supported by the grant of the Korean Health Technology R&D project through the Korean Health Industry Development Institute, funded by the Ministry of Health and Welfare, Republic of Korea. Thank you.